Hi everybody, this is the pre-class PowerPoint on the liver, which, as you remember, is one of the accessory organs to the GI tract because it does make secretions that help you digest and absorb nutrients. As always, let's start with a little review of the anatomy. This is the liver, okay? The liver has a dual blood supply. It gets blood from two places. The little red arrow there is pointing at the hepatic artery, which brings oxygenated blood to the liver from the abdominal aorta. Okay, and now you see the red arrow pointing at the portal vein, which brings blood to the liver from the GI tract. And since the blood's coming from the GI tract, that means it has fats and carbohydrates and proteins in it that were absorbed from the GI tract, and those are being carried to the liver so they can be metabolized. So you remember the functional unit of the liver is called the hepatic lobule. And as you can see in the slide, it's made up of rows or sheets of hepatocytes, which is just the fancy word for liver cell. And those hepatocytes sort of spread out in all directions from around a central vein that you see in the lower right-hand corner of that picture. Now, you'll notice as you look at that picture, there are sort of like two sets of tubes or two sets of vessels that run through the hepatic lobule. The first set of tubes are blood vessels. They're actually capillaries that we call sinusoids, and those are like the bluish colored vessels in that picture. Now, the sinusoids get blood from the branches of the hepatic artery and the portal vein, and they channel the blood through the hepatic lobule to the central vein, which then, takes the blood back to the general circulation. But while the blood is passing through the sinusoids, two things basically happen. First of all, the nutrients in the blood that's coming from the portal vein get transported into the liver cells where they can be metabolized. The second thing that happens is there are phagocytic cells in the sinusoids. You see in this picture the little red arrows pointing at a Kupffer cell. And the Kupffer cells are phagocytic cells that are there to sort of clean up the blood. Because remember, we're getting blood from the GI tract here. And you remember your GI tract is not sterile, right? So it's possible that bacteria or other kinds of foreign substances might have entered the portal circulation from the GI tract. So as the blood then circulates through the liver, the phagocytic cells and the sinusoids kind of clean it up and get rid of anything that doesn't belong. Okay, the second set of tubes or vessels that run through the hepatic lobule are called bile canaliculi. And they're just like little teeny weeny bile ducts. And their job is to collect the bile that's made by the liver cells and channel them towards the hepatic duct. Okay, so as the liver cells make bile, the bile drains into the bile canaliculi, and then from there they get carried to little bigger ducts and then little bigger ducts until eventually they drain into the main hepatic duct that you see the little red arrow pointing at in this picture. And so the hepatic duct kind of drains all of the bile that's being made by the liver cells down out of the liver, and then the hepatic duct kind of joins up with the cystic duct from the gallbladder, and together they continue on as the common bile duct. And then eventually the common bile duct joins up with the pancreatic duct, and eventually everything drains into the small intestine through the ampulla of Vater and the sphincter of Oddi. Now, when you look at all of these bile ducts, both the ones that are inside the liver as well as the ones that are outside the liver, eventually draining into the small intestine, collectively, we usually refer to all of those bile ducts as the hepatobiliary tree. Okay, so if you see that term in your textbook or whatever, we're referring to all of the bile ducts, both inside and outside the liver. Now, the liver is a very busy, very important organ. As you can see, it does all kinds of stuff. As a matter of fact, it does way more things than these, but what I've tried to do is to summarize the most important of the functions of the liver into a shorter list that you're more likely to remember. So we've got 6 primary functions of the liver there on the slide, as well as they're listed in your study guide. And I want to go through each of these little functions in a little bit more detail. Let's start with the first one on the list, bile synthesis. That's the thing that most people think of when they think about the liver. The liver makes bile. And why do you need bile? Remember, bile helps you digest and absorb your fats and your fat-soluble vitamins. Now, bile contains a whole bunch of things. See in this picture some of the different kinds of things that are in bile, but the biggest thing, or the thing that you have the most of in your bile, is bile salts. And the bile salts are made by the liver from cholesterol, and this is the part of the bile that actually helps you digest and absorb your fats. Remember seeing that picture last class period? It illustrates how the bile salts help emulsify the fats, break them into tiny pieces so they can be acted on by the pancreatic lipase and then digested, so then they can be absorbed through the GI wall. So that's the job of the bile salts. The only other thing that is in bile that I want to mention is bilirubin. And I'm sure you remember seeing this little slide before when we were talking about bilirubin and where it comes from. Now you remember bilirubin is a breakdown product of red blood cells, right? When we break down old or defective red blood cells, one of the waste products you get is bilirubin. And what happens is when the red blood cells break down and then we get the bilirubin as a waste product, that bilirubin is circulated through to the liver, and then you see in that little box there that's drawn on top of the liver, what's going on there is the liver is taking the bilirubin that comes to it and is conjugating it. And conjugate is just a big word that means the liver is joining or combining the bilirubin with some other substances that make it water soluble so it can be excreted in the bile. Okay, so what the liver does is it takes unconjugated bilirubin that you see in step 3 there, the unconjugated bilirubin, and the liver conjugates it, which makes it water soluble. So now the bilirubin can go into the bile, and remember the bile then goes into the GI tract, and then the bilirubin in the bile just stays in your GI tract and eventually gets eliminated in the stool. So the bilirubin gets out of the body through the bile and the stool. Okay? Now, you remember that bilirubin is a pigment, right? We said it was the pigment that gives bile this kind of strange yellowish brownish color, and it's also the same pigment that gives stool its yellowish brownish color, because remember the bilirubin does go out in the stool. Now, usually when this whole process is working, there's only a small amount of bilirubin in the blood because the rest of it gets eliminated in the stool. Sometimes, though, we see people who have abnormally high amounts of bilirubin in their blood, and if that's the case, what problem do people have? They have jaundice, right? That's when the skin and like the whites of the eyes and those kinds of things turn yellow. Here's another picture of it, because of course it doesn't look the same in everybody, so I'm giving you a couple of different pictures to look at. Here's another one, because sometimes, people are sort of yellow, but you don't notice it until you compare them to what it is they're supposed to look like. Okay, back to the functions of the liver. The next thing on the list is that the liver is supposed to help metabolize nutrients like carbohydrates, fats, and proteins. Okay, so remember the liver is getting blood from the portal vein, which has picked up or absorbed carbohydrates, fats, and proteins from the GI tract. And now those nutrients are going to the liver to be metabolized. And what we mean by metabolized is that the liver takes those nutrients and changes them into whatever form that the body needs at that moment. Okay, so let's take a closer look at what the liver does in terms of each of those three main nutrients. Okay, as far as carbohydrate metabolism goes, the liver usually follows the direction of the endocrine hormones like insulin and glucagon. Okay, and under the regulation of those two endocrine hormones, the liver is either going to store glucose in the form of glycogen, or it's going to break down glycogen and release glucose into the blood, depending on which one it is that you need in order to keep your blood glucose levels stable. Okay, so, for example, if you have too much glucose in your blood, okay, the liver's going to pick up that glucose, convert it into glycogen, and store it, okay, so that it's out of the blood. Now, if the liver has stored all the glycogen that it can hold and your blood glucose levels are still too high, the liver will take that extra glucose and convert it into fat and store it in that form. On the other hand, if your blood glucose levels are too low, the liver will take some of the glycogen it's stored, break it down, and release glucose into the blood. And if the liver's broken down all the glycogen it has and your glucose levels are still too low, the liver can actually make new glucose out of things like amino acids or glycerol or lactic acid. And remember, we call that particular process gluconeogenesis, right? If you break down that word, you can see exactly what it is. Gluco refers to glucose, neo means new, and genesis means like creation, right? So we have creating new glucose. So the liver can make new glucose out of amino acids and those kinds of things if you still need glucose after it's broken down all of its glycogen. All right, what about protein metabolism? What does the liver do in terms of protein? Well, the liver does a whole bunch of things. Okay, first of all, it can take proteins and break them down into amino acids. Or it can take some amino acids and convert them into other amino acids. You remember studying in nutrition that we usually divide amino acids into two groups, right? We have the essential ones and the non-essential ones. Now remember, the essential amino acids are considered, quote, essential because your liver cannot make them, right? So that's why it's essential that you get those in your diet. Whereas the non-essential amino acids your liver can make. So what happens is if you have extra of certain kinds of amino acids and not enough of others, the liver can take some of the ones that you have more than you need and convert those into the non-essential amino acids that you need more of. Okay, but remember, the liver can only make the non-essential ones. So if you're low on certain essential amino acids, well, the liver can't help you with that. Okay, but if you're low on non-essential amino acids, the liver can make those. So that's another thing that it does. So what else does the liver do in terms of protein metabolism? Well, the liver can take amino acids and make new proteins out of them. The liver makes lots of different kinds of proteins. For example, liver enzymes. Okay, you remember what an enzyme is, right? An enzyme is a protein that serves as a catalyst for all of the different kinds of chemical reactions that go on inside your cell. So every cell has to have a set of enzymes, including your liver cells. And the liver has to make all of the enzymes that it uses in order to carry out all of the chemical reactions that go on inside all of its cells. And on this slide, you see some examples of enzymes that the liver makes that operate inside the liver cells. I don't expect you to remember all of those. Those are just there as examples for you. The liver also makes clotting factors. Remember that from back when we talked about the blood, right? And again, this is just a list for you to see the different kinds of clotting factors that the liver makes. I don't expect you to memorize these, okay? But the liver does take amino acids and makes clotting factors. And the liver also makes plasma proteins like albumin. And again, this is just for illustration. I don't expect you to remember all of these. But I do want to call your attention to the fact that the albumin, one of the plasma proteins that we've been talking about, that's made by the liver. You remember albumin is the plasma protein that gives your blood its osmotic drawing power. In this little slide, you can see that albumin is usually too big to leak out of the capillaries and the blood vessels through the little pores in the vessel wall. So the albumin normally it stays inside the blood vessel and it attracts water. So that's kind of an illustration of the osmotic drawing power that the albumin has. But the point being that these are all examples of proteins that the liver makes. Liver enzymes, clotting factors, plasma proteins, and so forth. Now, the liver does one more important thing in terms of protein metabolism, and that is the liver takes ammonia, which is a breakdown product that you get when you metabolize protein, and it converts that ammonia to urea so it can be excreted by the kidneys in the urine. Okay, and that's a very important function because ammonia is considered very toxic, especially toxic to neurons. Okay, so it's very important that we keep the level of ammonia in the blood low. And the only way we can get rid of the ammonia is to convert that ammonia to urea so it can be excreted in the urine by the kidneys. So, very important function of the liver in terms of protein metabolism. All right, what about fat metabolism? What does the liver do there? Well, the liver can take triglycerides and break it down into fatty acids and glycerol, and then, we can use the fatty acids to produce ATP. Or the liver can take fats and make lipoproteins out of them. You remember HDL and LDL? Okay, those are made in the liver. The liver also makes phospholipids out of fats. Phospholipids are very important components of your cell membrane. You have to have that to repair your cell membranes and keep them in good working order. Those are made by the liver from fats. Okay, and then also the liver is very involved in the metabolism of cholesterol. The liver can make cholesterol if you don't have enough of it, because hard as it may be to believe, there are some people who don't have enough cholesterol. And if you remember from our discussion when we talked about the circulatory system, cholesterol in and of itself is not bad, right? You need some cholesterol because you use it to repair your cell membranes, you use it to make bile salts, and we also use it to make certain steroid hormones. Okay, so you have to have some cholesterol, and if you don't have enough, your liver can make some. Okay, or the liver can recycle cholesterol that you have, or the liver can get rid of some cholesterol in the bile. It can excrete cholesterol if you have too much of it. So the liver is very involved in cholesterol metabolism. In this little slide here, you can see a bunch of the different things that we just mentioned being listed as part of the liver's jobs. All right, more functions of the liver. We already said the liver is involved in the metabolism of carbohydrates, fats, and proteins. It's also involved in the metabolism of vitamins and minerals. Okay, so not just the metabolism, but also the storage of vitamins and minerals. One of the things that the liver does is it can store vitamins and minerals. Because, from day to day, your diet may vary a lot, okay? Some days you eat really healthy and you get more vitamins and minerals than you need. And other days, maybe you only eat junk food and you don't get enough vitamins and minerals. So what your liver does is on the days that you get more vitamins and minerals than you need, it can store those. And then on the days where you only eat junk food, it can release some of those vitamins and minerals so that your cells can still function. Okay, now, your liver is actually even more important in terms of fat-soluble vitamins besides just storing them for times when you need it. Because remember, what is it that you need in order to absorb a fat-soluble vitamin? Okay, people always want to say fat, okay? But so what do you need to absorb fat? Okay, you need bile, right? So you also need bile to absorb your fat-soluble vitamins. And bile comes from your liver. So the liver is even more important in fat-soluble vitamins because you need it to absorb the fat-soluble vitamins from your diet as well as to store it for times when you might need it. Now, do you remember what your fat-soluble vitamins are? Right, they're A, D, E, and K. And in the case of vitamin D, the liver is even more important than just making bile to absorb it. Because remember, your liver helps your kidneys activate vitamin D, right? So you remember the activation of vitamin D is a two-step process. The first step occurs in the liver. The second step is done by the kidneys. And then after that, now you have active vitamin D. And you remember why we need vitamin D? Right? It was to absorb calcium. Okay, so the liver playing a big role in the metabolism of all of your vitamins and minerals, but especially of your fat-soluble ones, and particularly vitamin D. All right. The liver also is involved in metabolizing drugs and hormones. Okay, think about that, right? Because when your body makes hormones or people take drugs, medications, and so forth, after the hormone or the drug does its thing, we got to break it down and get rid of it from the body, right? Otherwise, it's going to build up to toxic levels. And that metabolism, that breakdown, is done in the liver. So this breakdown of drugs and hormones by the liver cells is done by a lot of the enzyme systems that we just talked about, how the liver had to make enzymes so it could do all of its jobs. Okay, so the liver makes these enzymes, and a lot of the enzymes, their job is to break down drugs and hormones. And most of these enzymes hang out in the endoplasmic reticulum of the liver cell. Remember when we were talking about the parts of the cell, we said one of the jobs of the endoplasmic reticulum was to house the enzymes that work within the cell. So inside the liver cells, we have the endoplasmic reticulum with a whole bunch of enzymes in there, and the job of some of those enzymes is to detoxify or break down drugs and hormones so then they can be excreted from the body. One of the things that happens is that fat-soluble drugs and hormones get converted to water-soluble forms, so then they can be eliminated in the urine by the kidneys. So what that means is if something goes wrong with your liver, okay, you can't break down the drugs, therefore you can't get rid of them, so we're looking at drug toxicities and potential hormone imbalances. Okay, I want to talk about one really important family of enzymes that you find inside the liver cells. We call them the cytochrome P450 enzymes. And the reason why they're important is because they're involved in a lot of the drug interactions that we worry about in our patients. When you get into pharmacology, you're going to talk about how this family of enzymes breaks down a lot of the medications that we give to our patients. But the problem is they're also involved in a lot of the drug interactions that occur in our patients. Let me tell you how that works. Okay, so the enzymes in the cytochrome P450 system break down a lot of drugs. But the problem is that a lot of drugs can in turn affect the amount or the activity of the enzymes in the system. Okay, so what you have is a family of enzymes that are breaking down drugs, but then we have certain drugs that can also increase or decrease the amount of enzymes in the system. So they affect each other. And sometimes when we put together certain drug combinations, then it becomes a problem. Okay, let me give you a couple of examples, and I think you'll start to see what I mean. Okay, so let's say we have a patient who's taking oral contraceptives because she doesn't want to get pregnant. Okay, and oral contraceptives are an example of a drug that is broken down by the enzymes in the cytochrome P450 system. Now, let's say that you take this patient and we put this patient on phenobarbital. Are you familiar with phenobarb? Okay, it is a sedative, but it also is used as an anti-seizure medication. So let's say we have this woman who's taking oral contraceptives and she has a seizure. Okay, so we put her on phenobarb. Okay, the problem here is that phenobarb is one of those drugs that actually increases the availability and the activity of the enzymes in the cytochrome P450 system. So if we take this woman who's on contraceptives and we add phenobarb to her drug regimen, it increases the activity of the enzymes in that family. And what's going to happen to your blood levels of oral contraceptives? It's going to drop, right? Because if you increase the activity of the enzymes that are breaking down the drug, the blood levels of the drug are going to drop. And if the blood levels of the oral contraceptives drop, what is this woman now at risk for? To get pregnant. Okay, so that's one example of a drug interaction that we need to be on the lookout for. Let's look at another example. Let's say we have a patient who's on warfarin, or the trade name for that drug is Coumadin. Are you guys familiar with Coumadin? What does it do? Okay, it prevents you from clotting, right? So we'll put patients on Coumadin if we want them to if we don't want them to have like DVT or pulmonary embolism or something like that. Okay, so we have this patient who's on warfarin, and warfarin is another drug that gets broken down by the enzymes in the cytochrome P450 system. Now, let's say we take this patient who's on warfarin and we add Tagamet to his drug regimen. You guys familiar with Tagamet? I think you can buy it over the counter now, so you've probably heard of it. The generic name for it is cimetidine, but what it does is it decreases acid production in the stomach. So over the counter it's sold as kind of like a medication for people with heartburn and stuff. Okay, so let's say we have this patient who's on warfarin and he starts having really bad heartburn. So he goes to the store and he buys over-the-counter Tagamet, and he starts taking it. Okay, the problem with that is Tagamet is an example of a drug that actually decreases the activity or the availability of the enzymes in the cytochrome P450 system. So if we put this patient on Tagamet and we decrease the activity of the cytochrome enzymes, what is going to happen to the blood levels of warfarin? It's going to go up, right? And if the blood levels of warfarin go up, what is this patient now at risk for? Bleeding. Very good. So the point I'm trying to make is that when we take care of patients, we do have to look at all the medications they're on and make sure that there aren't any combinations of drugs that could potentially cause problems. This is the reason why when you do a care plan on the patient you're going to take care of, we want you to look up the medications and we want you to look to see, are the medications that they're on appropriate, or are there combinations there that might cause a problem, or things that we need to keep our eye on? So we're not just doing busy work when we ask you to do drug cards and stuff. There is a purpose for that. All right, more functions of the liver. The liver filters the blood. Actually, we already talked about that one, right? Because remember we said that in your sinusoids you have phagocytic cells called Kupffer cells, and their job was to phagocytize any bacteria or foreign particles that might have gotten absorbed from the GI tract and then carried to the liver. So in a way, the liver is like a filter that cleans up your blood. I ran across this cartoon one day that I thought was really appropriate for the liver. The mom says, "Have some liver, Jeremy." And Jeremy says, "No thanks. I prefer not to eat another creature's poison filter. But that's just me. Bon appetit." Okay, so, yeah, it sounds gross, but if you think about it, your liver, cleans the blood. So it is a poison filter. Okay. The last function of the liver we're going to mention, it stores blood. Okay, the liver actually has a really massive network of blood vessels. And so you can actually store a whole bunch of blood in your liver, maybe anywhere from 500 to 1,000 milliliters of blood, depending on your size. And, that's going to affect how much blood your liver can actually store. But that's quite a lot of blood. That's maybe 1 or 2 units of blood that you can, quote, self-transfuse, because we can shift a lot of that blood back into the general circulation if our blood pressure drops or our blood volume drops. And so this can actually be a useful thing if you lose blood. All right. If you look at this list of things that the liver does, okay, that's a pretty impressive list. So can you see how if your liver function becomes impaired, again, this is going to affect pretty much every system in your body, right? So when we get to talking about liver failure and cirrhosis, we're going to come back to this list of functions of the liver and see the kinds of problems that develop when your liver fails. All right, so we're going to talk about 2 common liver disorders today, starting with viral hepatitis. Now, the term hepatitis just refers to inflammation of the liver, and of course the liver could be inflamed by exposure to drugs or certain toxic chemicals, but we're focusing today on viral hepatitis, so we're only going to look at the kind of hepatitis that's caused by infection with hepatoviruses, meaning a virus that primarily affects liver cells. Now, if the liver becomes inflamed, of course you expect there to be some degree of discomfort, right? GI distress, abdominal pain, that kind of thing. And when the liver becomes inflamed, there is going to be swelling of the little bile canaliculi and the little ducts that drain the bile. And so if those little ducts get swollen and they become obstructed, then, you're going to be retaining bilirubin, and you do expect there to be some degree of jaundice. But usually, the liver should still be able to do all of those functions that we just got through talking about. If, however, the inflammation becomes very severe or chronic, then there might be some more permanent damage done to the liver, and it could eventually progress to cirrhosis and liver failure. So again, we want to catch things early so we can make sure things don't progress to that point. So under normal circumstances, the liver should be able to do almost all of those things on the list of functions. So, I'm sure you know there are several types of viral hepatitis. We have hepatitis A, hepatitis B, hepatitis C, all the way on up to hepatitis G. But
What we once thought was hepatitis F turned out to just be some weird variant of hepatitis C. So there really isn't a hepatitis F. And while there is a hepatitis G, it doesn't seem to cause clinical liver disease, at least in people. So we're only going to talk about hepatitis A through E. And that's plenty, don't you think? Because whenever there's more than one kind of something, on the test, I'm going to be asking questions to see if you know which one is which and what the differences between them are. So let's talk about what the differences are. These are the things that I want you to listen for as we talk about the different kinds of hepatitis. How are they transmitted? What is the incubation period? Do they cause chronic hepatitis or not? Do they have a carrier state? What are the serologic markers? Those are the ways that the different types of hepatitis are different from each other. First, though, let's define a few of those terms. First of all, chronic hepatitis. We usually consider hepatitis chronic if the inflammation lasts for longer than 3 to 6 months. And the reason why we're concerned about chronic hepatitis is because if the hepatitis does become chronic, it is much more likely to lead to cirrhosis, liver failure, and liver cancer. Carrier state. A carrier is somebody who is infected with the virus, who can pass it along to other people, but who doesn't have any symptoms themselves. And when we talk about serologic markers, we're referring to markers that we find in someone's blood or someone's serum, right? That's why we call it serologic. And usually these markers that we're looking at are viral antigens or antibodies. But we're interested in these markers because we can use them either to diagnose somebody with hepatitis or to monitor their status as far as whether they're still infectious or not. Okay, now there are several types of serologic markers, but we're only going to talk about the ones that we most commonly look at in the clinical setting. All right, let's talk about hepatitis A first. Hepatitis A is caused by the hepatitis A virus, which you see abbreviated as HAV. And this is the one that we used to call infectious hepatitis because this is the one that's transmitted by the fecal-oral route. Now, knowing that hepatitis A has a fecal-oral transmission can help us to make sense of who some of the high-risk groups are. For example, we frequently track epidemics to a restaurant where they were selling shellfish that was caught from contaminated water. Or maybe to a local market where they were selling milk from a dairy where the milk had gotten contaminated. And of course, when I say contaminated, I mean contaminated by sewage, right? Because this is a fecal-oral transmission. Sometimes we track epidemics to daycare centers or preschools where the kids are not yet potty trained and they're still at the age where they're put everything in their mouth. Right? And so they pick up the infection at daycare and then they take it home to their families and it kind of spreads from there. People who travel to countries where the sanitation is poor, might pick up an infection there and then bring it back home. So travel to a lot of third world countries is a risk factor. And then we have what we call high-risk sexual behavior. And keeping in mind that this is a fecal-oral transmission, we're probably talking about some kind of oral anal contact being involved. Okay, so we're not here to judge people, right? But we do want to teach them that hygiene is really important. Now, the good news about hepatitis A is it doesn't have a carrier state, and it doesn't seem to cause chronic hepatitis. As far as serologic markers, what we're looking for primarily is the antibody to the hepatitis A virus. So you remember HAV stands for hepatitis A virus. We put anti in front of it, that stands for antibody. So we look for the antibody to the hepatitis A virus to help us diagnose whether the patient does indeed have hepatitis A or not. You remember when we talked about the immune system in Unit 1, we did say there were several classes of antibody. We would look for both the IgM and the IgG version of the antibody to the hepatitis A virus. And if you remember, we also said that IgM was the first antibody to appear in response to an infection, but it doesn't stick around for very long, right? So if you see the IgM version of the antibody to the hepatitis A virus around, you know that this person has a very recent or a current infection. Whereas if you only see the IgG version of the antibody around, you know this person had hepatitis A at some point, but you don't really know when. You know, it could have been last month, it could have been last year. We know at some point they had it, but we don't really know when. Okay, the good thing about IgG, though, is it does hang around for a long time, and as long as you see that IgG antibody in the blood, you know that person has longer-term immunity and should not get hepatitis A again. Does that make sense? There is a vaccine for hepatitis A. We frequently give it to people who are planning to travel to other countries where there might be a lot of hepatitis A. And it is also one of the routine childhood vaccinations now because so many people send their kids to daycare or preschool that, it's a good idea to just protect all kids. If you have somebody who you know is exposed to hepatitis A and they are not vaccinated, we can give them an injection of gamma globulin to try and protect them from getting an infection this time, but of course the gamma globulin doesn't last forever. It's not going to provide the long-term protection that a vaccine would. So we would probably, in addition to giving the gamma globulin, at some point we would also want to vaccinate that person as well. And this slide is just to remind you the difference between giving somebody gamma globulin versus giving them a vaccine, whether it's passive or active immunity. If you need to review that, do that because I might test you on that on the final. All right, let's talk about hepatitis B now, caused by the hepatitis B virus. Hepatitis B is transmitted through blood and body secretions. So it makes sense, right, that there would be different high-risk groups for hepatitis B than there were for hepatitis A. Now, when you say transmitted through blood, the first thing that pops into people's minds is usually getting it through a blood transfusion. But do keep in mind that the blood banks have been screening donations for hepatitis B for a long time, so transmission through blood products is very, very minimal. Most of the time when people get hepatitis B from blood, it's usually IV drug users who share needles, but it could also be healthcare workers or anybody else who's exposed to a lot of people's blood. Okay, so you all fall into a high-risk group, which is the reason why you are all required to be vaccinated against hepatitis B. So you can see from this little chart that not all body secretions have the same amount of risk associated with it. But, people who share needles or healthcare workers, exposed to a lot of blood, so do fall into that high-risk group. Infants born to infected moms also fall into a high-risk group because the transmission usually is not in utero, but it's through exposure to the mom's blood during delivery. So there's that blood exposure again. You also notice that semen and vaginal secretions do have a moderate risk. And so, as you might imagine, high-risk sexual behavior is also on this list of risk factors. Only this time, since it's blood and body secretions and not fecal oral, now we're talking more unprotected sex or having multiple partners. Unfortunately, hepatitis B does have a carrier state, and it can cause chronic hepatitis, and so it is considered a risk factor for cirrhosis and liver cancer. As far as serologic markers, hepatitis B probably has the most complicated set of serologic markers. You'll see there are actually 3 antigens and 3 antibodies that we think about in connection to hepatitis B. And to really understand these markers, we probably need to know a little bit about the structure of the hepatitis B virus, because all the hepatitis viruses are a little bit different from each other. The hepatitis B virus has an inner core where the viral DNA is located, and then that inner core is surrounded by an outer envelope. Okay, so let's look at the 3 antigens first. The antigen that we're most interested in is the hepatitis B surface antigen, which is first on that list of antigens. And by the way, AG is the abbreviation for antigen. Okay, so HBsAg, that's hepatitis B surface antigen. And you'll notice that the hepatitis B surface antigen is found on the surface of that outer envelope. So it makes sense why we call it the surface antigen, right? But the reason why the hepatitis B surface antigen is the antigen that we're most interested in is because as long as we see that surface antigen in the blood, we know this patient can give hepatitis B to other people. Now, let's look at the other 2 antigens. We have the hepatitis B core antigen with the little c in it, and the hepatitis B envelope antigen with the little e in it. So in this diagram, you can see the hepatitis B core antigen is represented by those red circles. Okay, so that's part of the inner core of the virus. And so you don't find it circulating in the blood all on its own. So it's really not useful as a serologic marker. The hepatitis B envelope antigen, you'll see represented by what looks like little X's or little crosses on the inner surface of that outer envelope. Okay, so you remember the surface antigen was on the outer surface of that envelope, but the envelope antigen is on the inner surface of that envelope. And you might find the hepatitis B envelope antigen in the blood, but it doesn't give us as much information as the surface antigen. If you look at this diagram, it shows you when you're going to find which antigen and which antibody in the blood, and you'll notice that the first thing that appears in the blood is the hepatitis B surface antigen. And you'll notice that it actually appears in the blood before symptoms even start, right? And you'll notice that the hepatitis B envelope antigen, represented by the little dots, okay, those don't appear until after the surface antigen appears, and it disappears before the surface antigen disappears. So do you see what I mean when I say that it doesn't really give any additional information that you don't already have from the surface antigen, right? So of the 3 antigens, the only one we're really interested in is the surface antigen, because remember, as long as we see the hepatitis B surface antigen, we know this person can give hepatitis B to other people. The envelope antigen would tell you the same thing, but it doesn't appear in the blood for as long, so it's not as useful. Okay, so then you might wonder, well, if the envelope antigen isn't as useful and you don't even find the core antigen in the blood, why do we even care about those other 2 antigens? Why don't we just focus on the surface antigen? Well, actually, we don't care about those other 2 antigens. The only reason why I'm mentioning them is because we are interested in their antibodies. Okay, so let's go back and look at the list of serologic markers and look at the antibodies. Okay, so notice that all 3 of the antigens that we mentioned have antibodies that go along with them, right? You remember the anti stands for antibody, right? So we have the antibody to the hepatitis B surface antigen, the antibody to the hepatitis B core antigen, and the antibody to the hepatitis B envelope antigen. Okay, so the most important antibody, the one that you want to see in the person's blood, is the antibody to the hepatitis B surface antigen. Okay, because once you see the antibody to the surface antigen, that tells you that the person can no longer give hepatitis B to other people. Okay, so they're no longer infectious. So going back to this graph, do you see the little dotted line that represents the antibody to the surface antigen? Okay, now remember, that's the one that you want to see in the blood, because when you see the antibody to the surface antigen, that tells you this person can no longer give hepatitis B to other people, and they are on their way to recovery. Okay, but also notice that there is a window of time between when the surface antigen disappears from the blood and when the surface antibody appears. Okay, and if you happen to draw a patient's blood during that window period, and if all you looked at was the surface antigen and the surface antibody, would you even know this person had hepatitis B? No, because neither of those two markers appears in that window period. That's why we're interested in the other two antibodies. Remember, there's an antibody to the hepatitis B core antigen and an antibody to the hepatitis B envelope antigen. And those two do appear in the window period. Now look again at this graph. Okay, so you see in that window period, after the surface antigen disappears, but before the surface antibody appears, in that window period, you do see levels of the other two antibodies present, right? So that's the reason why we care about those other two antibodies. They don't tell us that the person is no longer infectious, because people are actually still infectious in that window period. They can give it to other people. So we're interested in those other two antibodies, not because they tell you the patient is no longer infectious, but because they can help us identify if somebody's in that window period. Does that make sense? So if we were to draw blood and, we don't find either the hepatitis B surface antigen or antibody, but we really think this person has hepatitis B, we would probably go back and look for those other antibodies to see if this patient might actually be in the window period. So to summarize, the hepatitis B surface antigen is the one that tells us the patient can give hepatitis B to other people. The antibody to the hepatitis B surface antigen is the one that tells us that the person can no longer give hepatitis B to other people. And then the other two antibodies can help us identify if the patient's in that window period where we don't see either the surface antigen or the surface antibody. Does that make sense? Now, there is a vaccination for hepatitis B, which you probably all got because it is required by OSHA, which is the Occupational Safety and Health Administration, required for everyone who might be exposed to blood in the course of their work. But we also have gamma globulin that we can give to people who were exposed but haven't yet been vaccinated. All right, hepatitis C, caused by the hepatitis C virus. You see, this one is also transmitted through blood. It can be transmitted through body secretions as well, but it's more through blood. So again, we're talking the high-risk groups involved, healthcare workers, IV drug abusers who share needles, high-risk sexual behavior. Now we're also looking at maybe transmission through tattooing and body piercing if the, people who are doing those procedures aren't sterilizing their equipment properly. Patients who receive hemodialysis, if that equipment is also not being cleaned and sterilized appropriately. People who receive organ transplants, and, blood and blood products, although the blood banks have been screening for hepatitis C since the early 1990s, so we really don't see that much hepatitis C transmitted through that route. Hepatitis C does have a carrier state, and it does tend to become chronic. In fact, hepatitis C is interesting because even though it tends to have the mildest symptoms of all the types of viral hepatitis, it is the one that's most likely to become chronic. I think your book says like 85 to 90% of all people who get hepatitis C go on to develop chronic hepatitis. And that's a bad thing because remember, chronic hepatitis makes it much more likely that the patient will progress to cirrhosis and then to liver cancer and liver failure. In this slide, HCC stands for hepatocellular carcinoma, which is cancer, and ESLD is end-stage liver disease, or basically liver failure. Hepatitis C is thought to be the most common cause of chronic hepatitis, cirrhosis, and liver cancer in the world. Now, there's a couple of different reasons why hepatitis C is so likely to become chronic. The first reason being that the virus is genetically unstable, meaning it mutates easily. Okay, so there are a lot of subtypes and different genotypes of the virus, and that makes it more likely to develop drug resistance. Plus, it also makes developing a vaccine against it really hard because the virus is always changing. So that's one reason why it's hard to get rid of hepatitis C, and so it is more likely to just linger and become chronic. The other reason why hepatitis C is more likely to become chronic, though, is because for some reason the hepatitis C virus doesn't seem to trigger a very strong immune response. Usually in response to a virus, the immune system will generate a lot of inflammation and it'll send white blood cells out to kill that virus-infected cell. And of course, the inflammation and the killing of virus-infected cells causes a lot of symptoms, right? People don't feel that great, but we're usually successful in wiping out the virus and the patient will get better. Since hepatitis C doesn't trigger a very strong immune response, there's not as much inflammation, we're not killing as many cells, so the patient doesn't feel as sick, but we are not as successful in getting rid of that virus. So the virus tends to hang around and the infection becomes chronic. So having milder symptoms might seem like a good idea, but it's really not because it means that we are less successful in getting rid of the virus and the infection is more likely to become chronic. Does that make sense? There is an antibody against the hepatitis C virus that we look for in the blood. This antibody, unfortunately, doesn't seem to be very effective in helping you fight hepatitis C, but it does allow us to diagnose that you have it. And as we mentioned earlier, there is not a vaccine against hepatitis C at this time. All right, hepatitis D, caused by the hepatitis D virus, or sometimes people call it the Delta virus. Hepatitis D is kind of an interesting disorder because you can only get hepatitis D if you already have hepatitis B. Okay, and of course if you get hepatitis D on top of hepatitis B, that just increases the severity of the inflammation and it does increase the likelihood of it becoming a chronic infection. Now, if you look at this picture of the hepatitis D virus, it kind of explains why you can't have hepatitis D unless you already have hepatitis B. Because if you look at this picture, notice that hepatitis D uses pieces of the hepatitis B surface antigen to form its viral coat. Okay, so hepatitis D is what we usually call an incomplete virus or a defective virus because it doesn't have a viral coat of its own. It has to use pieces of the hepatitis B surface antigen molecule in order to make its viral coat. So it makes sense then, right? If there is no hepatitis B around, then hepatitis D cannot survive because it won't have a viral coat. Okay, so since you have to have hepatitis B in order to get hepatitis D, the risk factors are pretty much the same as for hepatitis B. The risk factor for hepatitis D is having hepatitis B, okay? And hepatitis D is transmitted in a similar fashion to hepatitis B through blood and body secretions, and it is also similar to hepatitis B in that there is a carrier state, and it can cause chronic hepatitis. As far as serologic markers, there is an antibody against the hepatitis D virus that we can use to diagnose that the person has hepatitis D, but again, it's not a very effective antibody in that it doesn't really protect you much. And there is not a vaccine for hepatitis D at this time, so what do you suppose we do instead? We vaccinate people for hepatitis B, right? Because you can't get hepatitis D unless you already have hepatitis B. So if we can prevent you from getting hepatitis B by giving you a vaccination for hepatitis B, then we're also protecting you against hepatitis D. All right, let's talk about hepatitis E. Hepatitis E has a lot in common with hepatitis A. They both are fecal-oral transmission, and neither of them tend to cause chronic hepatitis or to have a carrier state. Now, I think maybe there's a couple of incidences where hepatitis E became chronic, but for the most part, neither A nor E become chronic or have a carrier state. So I always remember that the two vowels, A and E, go together, and then B, C, and D are also similar in that they are transmitted through blood and body fluids, and they do have the chronic hepatitis and the carrier state. Now, even though hepatitis A and E are similar in many ways, there are a few differences. For example, hepatitis E tends to occur mostly in developing countries, or what we call third world countries. Hepatitis A can happen in the United States. We have very little hepatitis E in the United States. So if you look at this map and you see the parts of it that are colored red, those are the areas where we see the most hepatitis E. And those do happen to be those third world countries where they don't have very good sanitation and so forth. The other difference between hepatitis A and E is that hepatitis A usually is fairly benign. It usually is self-limiting. In other words, it'll usually go away on its own without a whole lot of extensive treatment. Whereas hepatitis E has a much higher mortality rate. And I don't know if that's because the hepatitis E virus is just more virulent, or whether it's because it tends to occur in those parts of the world that don't have as good sanitation, where the people are poorer, so they may not have as much good nutrition, good health care, all the resources available to them. It could be a combination of both. Now, there is a serologic marker that can be used to identify hepatitis E, but it's really not widely available commercially. Usually it's mostly research labs where they have access to it. And the same is true for vaccines. There is a vaccine that has been developed for hepatitis E. It also is not widely available, although I understand that they are making quite a lot of it and using it in China. But as far as the rest of the world, there really isn't much access to hepatitis E vaccines. Again, that seems to be mostly available to research labs. And I think the reason for that is because since hepatitis E doesn't happen very often in the richer countries of the world, those countries aren't very interested in investing money in developing serologic tests or developing vaccines, because there just isn't very much hepatitis E in those countries. The countries where there is a lot of hepatitis E, those tend to be the poorer countries, and they don't have the money to invest in manufacturing a lot of vaccines or developing a lot of diagnostic tests. And unfortunately, that's kind of the way the world works. All right, assessment findings for hepatitis. The assessment findings tend to be similar regardless of which type of hepatitis it is. The symptoms are more going to differ according to what phase of the disease the person's in. So you probably remember studying in biology or some science course somewhere along the line that a lot of infectious diseases go through these different phases. You know, they start with an incubation period, and then there's a prodromal period, and then an illness phase, and then they start getting better, and then they convalesce and they recover, okay? In the incubation period, the patient is infected, but they don't have any symptoms yet, because that's what the incubation period is, right? It's a time where they're infected, but they don't have symptoms yet. And as far as how long the incubation period is, that depends on which kind of hepatitis we're talking about. Now, I don't expect you to memorize how long the incubation periods are for the different kinds of hepatitis. I just wanted to show it to you so you can notice that the incubation periods can be pretty long in some of these kinds of hepatitis, and that they vary greatly from one type to another. Moving on to the prodromal period, in hepatitis, we sometimes call the prodromal period the pre-icteric phase. Do you know what the word icterus means? Icterus means jaundice, so the pre-icteric phase is the time where the patient is starting to feel sick, but they haven't turned yellow yet. Okay, so there is some inflammation and some damage to the liver cells already occurring. People are going to maybe have a fever and some malaise. They're going to have the body aches, you know. They're going to lose their appetite. There might be some mild right upper quadrant pain because, you know, your liver is there in your right upper quadrant. Maybe some generic types of GI symptoms, some nausea, some diarrhea or constipation, but nothing that really seems out of the ordinary yet. You know, up till this point, it could be any kind of infection. Moving on to the illness phase, in hepatitis, we often call this the icteric phase, meaning now the person turns yellow. And, you know, once they turn yellow, then it's fairly obvious where the problem is, right? It's with the liver. Now, how jaundiced or how yellow the patient turns is going to depend on how much inflammation develops and how swollen those little bile ducts get. Because if the bile ducts get really swollen, that's going to block the outflow of bile from the liver, and the bilirubin is going to build up in the body and in the blood, and the person's going to turn yellow. Now, if the person has a lot of bilirubin and bile acids in their skin, you know, the bilirubin and the bile acids are kind of irritating to the skin, and so the patients are probably going to develop itching. We call that pruritus. Okay, so the pruritus goes along with the jaundice. The more bilirubin and stuff in the skin, the more itchy the person's going to feel. Now, again, depending on how swollen and how obstructed the bile ducts are, you know, if we can't get the bile out of the liver, then you might see some changes in the color of the stool and the urine. If the bile, and therefore the bilirubin, can't get into the GI tract, you're going to see what we call light-colored or clay-colored stool. Because you remember, bilirubin is a pigment. It's the pigment that gives your stool its normal yellowish-brownish color. So if the bilirubin is absent, the stool is going to be very light-colored. Now, if there's a lot of swelling and obstruction in the bile ducts and the bilirubin isn't able to get into the stool, then the body's going to look for other ways to get rid of that bilirubin. And one of the ways it might try to get rid of it is in the urine, in which case now the pigment is in the urine, and so the urine is going to become darker colored. And here you see a picture of what that darker urine might look like. Some people call it liver urine or bilirubinuria, okay, to refer to the bilirubin in the urine. But remember that you aren't going to see a change in the color of the urine unless there is also a change in the color of the stool. Because if the bilirubin is getting out in the stool, then there's no need to get rid of it in the urine, right? Of course, if the liver is inflamed, as it would be in a hepatitis, you would see some liver enlargement, so some hepatomegaly, and some liver tenderness. So if you were palpating the abdomen in the right upper quadrant, there would be some tenderness there. We might also expect to see an elevation in certain liver enzymes in the blood. AST and ALT are probably the two that we look at the most. I don't expect you to remember what AST and ALT stand for, but I do expect you to recognize what they are, that they are liver enzymes that are normally found inside liver cells. And if you find high levels of them in the blood, what does that tell you? It tells you that liver cells have been damaged and their insides are leaking out, right? So in hepatitis, when there's inflammation of the liver, we would expect to see some elevation in AST and ALT. All right, and then eventually the patients will start to recover. They'll enter the convalescent phase. And here we're going to see their jaundice gradually going away, their appetite gradually returning, and they're going to start to feel better. As far as interventions for hepatitis, mostly what we're doing is we're treating the symptoms while we give the liver a chance to recover on its own. By treating the symptoms, we're talking about things like giving IV fluids if they're getting dehydrated, maybe nutritional support if they're not eating well. Mostly, though, we're just doing supportive care while we wait for the liver to recover. And, of course, we're avoiding anything that might further stress the liver, anything that might be what we call hepatotoxic or hard on the liver. So things like alcohol, right? People with hepatitis should not be drinking alcohol, and we have to be careful what medications we give them because a lot of medications are somewhat hepatotoxic. And so we have to be careful which drugs we choose to use, and we may need to use lower doses of them. Now, you would think, wouldn't you, that since this is a viral hepatitis, that we might want to give some antiviral drugs. But the problem is a lot of antiviral drugs are hepatotoxic and might actually make the situation worse. So if we think the patient will be able to recover on their own without antivirals, we'll probably go that route. Usually we only bring antiviral medications out for chronic hepatitis because chronic hepatitis does have that increased risk of predisposing to cirrhosis and liver failure and liver cancer. It might be worth the risk to bring out the antiviral medications. The one exception to that, the one time that we might bring antivirals out for acute hepatitis is with hepatitis C. Since it does have such a high rate of becoming chronic, we will probably go ahead and give antiviral medications for acute hepatitis C with the goal of preventing it from becoming chronic. All right, let's move on and talk about cirrhosis. Now, cirrhosis is a disorder in which a lot of your functional liver tissue has been replaced by fibrous tissue or scar tissue. So you might find little nodules or small areas of normal liver cells, but those normal cells will be surrounded by a lot of scar tissue. So in the picture on the right, you can see those bands of scar tissue that's kind of running through the liver, and then in between those bands of scar tissue, there are normal liver cells. And so over time, you might notice the liver starting to become kind of lumpy looking and misshapen because of the bands of scar tissue that are surrounding the little nodules of normal liver cells. Now, cirrhosis usually starts with damage to or death of liver cells. And the damage or the death of liver cells can be caused by a number of different causes, which we'll talk about in a minute. But for now, let's just say that cirrhosis starts with damage or death of liver cells. And after those cells get damaged or they die, there is some cell regeneration. And that's what leads to the little nodules of normal liver cells. But those little areas of normal cells are surrounded by large areas of scar tissue or fibrosis. And that fibrosis causes a couple of different problems. First of all, does scar tissue do all the stuff that regular liver cells do? No. Okay, so if enough normal liver cells get replaced with scar tissue, eventually we're looking at a liver failure situation. The second problem with having all those bands of scar tissue running through the liver is that you remember that scar tissue, after a while, it contracts, right? If you've ever had a bad cut or, a big wound that healed over and there was a lot of scarring present, you know that after a while, it could be a few years, but after a while that scar tissue does start to shrink, right? So eventually the scar tissue constricts. And if you have a lot of scar tissue in your liver, when those bands of scar tissue constrict, it starts to distort the shape of the liver. In this picture, you can kind of see how badly distorted the liver can actually get. But the problem with it having those bands of scar tissue constrict is that when it distorts the shape of the liver, that causes some kinks or obstructions in those two sets of vessels that we said run through the liver tissue. So remember we said there were two sets of vessels in the hepatic lobule, right? There are blood vessels and there are bile ducts. Okay, so when the scar tissue starts to distort the structure of the liver, there are kinks that develop in these two sets of vessels. And if you kink or bend the blood vessels, now you're obstructing the flow of blood through the liver. And if you kink or bend those bile ducts, now you're obstructing the flow of bile out of the liver. And those two problems cause a lot of the symptoms that we see in cirrhosis. Before we talk about what those symptoms are, though, let's back up and talk about what were the things that caused that initial damage or death of liver cells that got the whole process of cirrhosis going. The cause of the damage to the liver cells depends on which kind of cirrhosis we're talking about. Post-necrotic types of cirrhosis usually have liver damage as a direct result of things like viral hepatitis or exposure to hepatotoxic drugs or chemicals. Primary biliary cirrhosis usually is autoimmune. So the immune system is attacking the bile ducts in the liver, and that's what's causing the damage. Alcoholic liver disease, also known as Leydig cirrhosis, alcoholic cirrhosis, micronodular cirrhosis. In those kinds of cirrhosis, the damage to liver cells is the result of the breakdown products of alcohol. So, when people drink a lot of alcohol, the liver has to break it down so it can be excreted from the body. And some of the breakdown products actually damage the liver cells. And we would call that alcoholic liver disease. Now, it does seem like there are also some genetic and environmental factors involved in alcoholic liver disease, because we noticed that not all alcoholics develop cirrhosis. Now, don't get me wrong, because all alcoholics do have some damage to their liver. It just doesn't progress all the way to cirrhosis in all of them. It probably only progresses to cirrhosis in only about 15% of alcoholics. But they all are going to have some degree of damage. Some alcoholics will get alcoholic fatty liver disease or alcoholic hepatitis, but only a small percentage actually progress to alcoholic cirrhosis, which is why they think that maybe there are also some genetic or environmental factors involved in that. But, it also probably depends on how you define what an alcoholic is. So, the last category of cirrhosis I want to mention is the kind that develops out of non-alcoholic fatty liver disease. Now, this is a growing segment of the liver disease population. And in bold, you see the newer name for this problem. I just read an article last week that said they are officially changing the name of the disorder to metabolic dysfunction associated steatotic disease, or MASLD. Okay, now that's a mouthful. But according to the article, the reason they're making the change is because they feel like this is a less biased name, right? Because I guess alcoholic or non-alcoholic and fatty liver, there's some stigma attached to some of those terms. And so they feel like, the newer term is better. So I'm guessing that you're going to start seeing that newer term more often, although the change is quite new, so you'll probably still see non-alcoholic fatty liver disease around a lot as well. But anyhow, the problem in MASLD is that there are a lot of fatty changes to the liver, a lot of fat deposits in the liver cells, and usually that change is associated with things like obesity, insulin resistance, diabetes mellitus, hyperlipidemia. If you think about it, it makes sense if people are, they have higher levels of fat in their blood, that kind of thing. There is going to be more fat deposits in the liver cells, and as fats accumulate in those liver cells, it impairs their ability to function. Okay, so there are going to be changes in the function of the liver that can lead to cirrhosis. And since we do have a growing problem with obesity, insulin resistance, type 2 diabetes, hyperlipidemia, then it kind of makes sense that there would be a lot more liver disease related to that as well. And here you can see all the extra fat that's located in the liver cells when they develop this fatty liver disease. Now, there may not actually be a lot of symptoms of cirrhosis until the disease is fairly advanced. But once they do develop, they're usually due to one of these three problems: inflammation, portal hypertension, or liver failure. So let's talk about these three things. So you remember back in Unit 1, we defined inflammation as the tissue's response to injury. And we did just say that death or damage of liver cells is the thing that gets the whole cirrhosis process going. So there is damage to liver cells, so there is going to be inflammation. And as part of the inflammatory response, you expect to see swelling and pain, right? So there's going to be enlargement of the liver, hepatomegaly, and some abdominal pain, probably in the epigastric or right upper quadrant area, since your liver is located in your right upper quadrant. Other symptoms of cirrhosis are due to portal hypertension. Now, what do you suppose portal hypertension is? Okay, it's basically what it sounds like. It's high blood pressure in the portal system. Now, the portal system is the portal vein and all of the vessels that are feeding into the portal vein, which you can see in this picture. And most of those vessels are carrying blood from the GI tract with all the nutrients that were absorbed from the GI tract and channeling it through to the liver to get metabolized. Now, the reason that the pressure in that portal system becomes high is because, remember, we said that as the scar tissue in the liver contracts, that distorts the structure of the liver, and it causes some kinks and obstructions in the blood vessels that are flowing through the liver. So if the blood, as it tries to flow through the liver, is hitting these kinks and obstructions, it's going to start to back up in that portal system. And so now the portal system has more blood in it, and the pressure in that system is going to increase. Okay, now you remember that as blood collects in blood vessels, the blood vessels start to get distended, but they can only stretch so much. And as more blood continues to accumulate in it, some of the fluid in the blood is going to get pushed out of those vessels into the spaces around it. If some of that fluid gets pushed out into the peritoneal space, what do we call that? We call it ascites. And you can see from this picture that sometimes a whole bunch of fluid can collect there, and the belly gets quite big, to the point where it can be very uncomfortable. It can even make people feel a little short of breath. If you ever had the experience, like maybe on Thanksgiving, where you kind of overate at dinner and you feel so full that you feel like you can't take a deep breath anymore, it's because your stomach is so full that your diaphragm can't descend as low as it usually does, and so you feel like you can't take a deep breath. You can only breathe shallow. That's the same kind of feeling that people with a lot of ascites get. Because there's so much fluid in that peritoneal space, it kind of prevents the diaphragm from going down as far as it usually does, and so these people feel like they can't take deep breaths. They do feel a little bit of short of breath. Now, if you're wondering how much fluid has to get pushed into the peritoneal space in order to get that much ascites, your book actually says that there can be like 15 liters or more of fluid in that peritoneal space. And if you're having trouble visualizing how much 15 liters of fluid is, okay, just think about those 2-liter soda bottles that you buy at the grocery store. 15 liters would be, 7.5 of those soda bottles? Okay, so you can understand why these people are so uncomfortable. So let's think for a minute about all of those internal organs that are sending blood through the portal system to the liver. If the blood can't get through the liver and the pressure continues to build in the portal system, that means the blood is eventually going to get backed up in these abdominal organs. And the spleen is one of the major organs that this happens to. Blood backs up into the spleen starts getting engorged, it gets enlarged, and now we have splenomegaly. And you remember we already talked about all the problems that go along with splenomegaly, right? Remember, one of the jobs of the spleen is to get rid of old or defective red blood cells, and if the spleen gets enlarged, it gets carried away, and it gets rid of more blood cells than it's supposed to. So now we're going to have people with anemia and thrombocytopenia and leukopenia, right? And I'm not going to stop to remind you what problems go along with anemia, thrombocytopenia, and leukopenia, because you should already know that, right? We covered that in Unit 1. But does it make sense now why the final exam is comprehensive? Because you can't forget the material that you learned in Unit 1. You need all of that to understand some of these other diseases that we're now covering. So if you don't remember these, look them up before the final exam, okay? Okay, one last problem I'm going to mention that results from portal hypertension is what we call portosystemic shunts. Okay, so you remember we said that because the shape of the liver got distorted, there are kinks in the blood vessels in the liver now, so the blood cannot flow freely through the liver. There's a lot of resistance to blood flowing through the liver. And so what's going to happen is the blood is going to start to look for alternate paths that it can follow that don't present as much resistance. So we're going to see blood flow getting diverted to smaller vessels that aren't used to having that much blood flow. And the problem is when we start sending a lot more blood through some of these smaller vessels, those vessels are going to become very distended, they're going to get fragile. When that happens, we call them varices or varicosities. And I'm going to mention 3 specific places that these varices or varicosities can develop. Okay, so a lot of extra blood gets sent through vessels in the anal and the rectal region. And so we see people developing what we call anal rectal varices. Now, what do you suppose the layman's term for anal rectal varices is? Hemorrhoids, right? So people with cirrhosis can develop some pretty bad hemorrhoids. Another place where we might develop these varices is in the vessels around the umbilicus, in the area of this drawing indicated by the number 2. So these umbilical vessels are vessels that usually don't have very much blood in them because we don't really need them anymore once we don't need our umbilical cord anymore after we're born. But when there is portal hypertension, there will be more blood in these vessels, and you might see them really becoming dark on the surface of the abdomen. When that happens, we call it caput medusae. And here's another view of how dark those vessels can become when they get full of blood. The last place I want to mention where we get these varicosities or varices is in the esophageal area where the esophagus joins to the stomach. There are several vessels there that lie just below the mucosa, and they start having a lot more blood flow going through them, which makes them kind of stick out. So you can see in this picture how those vessels are just sort of sticking out into the lumen of the esophagus. And the problem with that is in this area, the tissue is exposed to a lot of acid and pepsin, to a lot of mechanical trauma from the food that we're swallowing. And so if anything happens to increase the pressure in those vessels, like maybe the person coughs or they vomit or they do the Valsalva maneuver, that increased pressure can cause those vessels to rupture, because remember, they weren't used to having that much blood flow, and so they got very distended and very fragile, and now they're more prone to rupture. Here's another picture where you can see the arrows are pointing to those vessels and how they just kind of stick out, and you can see how easily they could become damaged. And one more photo that shows you how those varices actually just sort of bulge out into the lumen of the esophagus. So I did mention the Valsalva maneuver is one of those things that can cause esophageal varices to rupture. And I find that a lot of students don't know what the Valsalva maneuver is, so let me just tell you. Okay. The Valsalva maneuver is that thing that people do when they hold their breath and they bear down. Okay, so like when they're sitting on the toilet, trying to have a bowel movement, or for women, when they're trying to push that baby out, okay, when you hold your breath and you bear down or you push, okay, that increases the intrathoracic pressure, and it can increase the pressure in those fragile, distended esophageal varices, and that is one thing that could potentially cause the varices to rupture. Now, if esophageal varices rupture, it can cause such big hemorrhaging that people can actually die from that. It can be fatal. We really need to be careful if the patient does develop esophageal varices, that we're trying to prevent them from doing anything that might cause those varices to rupture, or we're prepared to take steps if those varices do rupture. All right, so those are the problems that can happen because of portal hypertension. And before we move on to talking about symptoms due to liver failure, I do want to mention that when we talk about somebody having portal hypertension, we're talking about high pressure in the portal system. That does not necessarily mean that their arterial blood pressure is high. Okay? So keep in mind it is possible for somebody to have portal hypertension, and yet when you check their blood pressure in their arm, it's normal. Okay, now they may have high pressure in both the portal system and high arterial blood pressure, but they're not necessarily correlated. Okay, so portal hypertension does not necessarily mean that there is high arterial blood pressure. All right, let's talk about the symptoms of cirrhosis that are caused by liver failure, because you remember we said that in cirrhosis there's a lot of scar tissue taking the place of normal liver cells, and since scar tissue can't do all those things that liver cells do, then the patient can go into liver failure. ESLD stands for end-stage liver disease. So let's go back and look at the functions of the liver and see if we can figure out what's going to happen if the liver fails. Now, you actually aren't going to see any signs of liver failure until you get to the point where like 80 to 90% of your functional liver cells are lost. So if you look at it one way, you actually have a lot of spare liver cells. But once you get to the point of liver failure, you remember one of the big jobs of your liver is to make bile. And if your liver's not making bile, what's the big problem? Okay, you need your bile in order to absorb your fats and your fat-soluble vitamins. So if you're not making bile, you can't absorb fats or fat-soluble vitamins. All right, so you remember that fat is a big source of energy in your diet, right? And so people who don't have bile are going to be tired, they're not going to have energy, and they're going to lose lean body mass. Right? Now, I'm not really going to say the cirrhosis patient is going to lose weight because they're retaining all of that ascites fluid and that kind of thing. So they're probably not going to actually lose weight, but they will lose lean body mass because they aren't getting the calories from the fats. The fats aren't being digested and absorbed. Now, if the fats aren't getting digested and absorbed, what's happening to them? Well, they're just staying in the GI tract, right? And then they're going to go out with the stool. So people get what we call steatorrhea, which means fatty stool, okay? And you can see in this picture, do you see like the oily fat that's left in there? As a matter of fact, if you look up the word steatorrhea in a medical dictionary, it's going to say stuff like the stool becomes frothy or it floats, or stuff like that. And in this picture, you can see what they mean by it floats, right? Because fat doesn't mix with water. It's going to float. And so if the fat is staying in the stool, it's going to make the stool really loose, and it'll be like diarrhea. Now remember, we said you need bile also to absorb your fat-soluble vitamins. So what were your fat-soluble vitamins? Well, we have A, D, E, and K, right? And I didn't put vitamin E in here because there's really no acute problems that we run into with vitamin E deficiency. But there are some issues with deficiencies of vitamin A, D, and K, right? So what do you associate with deficiency of vitamin A? Okay, vision problems, right? Maybe some night blindness and things like that. What about vitamin D? Well, we've said that you need vitamin D in order to absorb calcium, right? So we might expect to see some hypocalcemia or some osteoporosis, weak bones, that kind of thing. Okay, and what do we need vitamin K for? Okay, remember we said that you need vitamin K to make a lot of your clotting factors in an active form. So if we have a vitamin K deficiency, we might be looking at some problems with not being able to clot. Okay, so also if we're not making bile, remember we said that bile is the way bilirubin gets out of the body, right? Bilirubin in the bile gets into the GI tract, goes out with the stool. So if the liver's not making bile, what problem are we going to have? The levels of bilirubin are going to go up. People are going to get jaundice. Remember when they have all that bilirubin and bile acids in their skin, they get itchy, right? So they're going to have pruritus. And, if there's no bilirubin in the stool, what happens to the color of the stool? It gets light colored, and if the bilirubin can't get out of the body in the stool, where is it going to try and get out? In the urine, right? So again, we're looking for changes in skin color, changes in stool color, changes in urine color. All right, a second function of the liver, to metabolize nutrients. Okay, let's talk about the carbohydrates first. So you remember we said that if the blood glucose gets too high, the liver is supposed to store some of it as glycogen. And if the blood glucose gets too low, the liver is supposed to break down glycogen and dump glucose into the blood, or it can make new glucose to bring the blood glucose levels up. Okay, so if the liver fails, it can't do either of those things, so we might see either hyper or hypoglycemia. If the liver fails, what problems with protein metabolism do you think are going to occur? Well, you remember your liver is supposed to make proteins, right? And one of the proteins that we said it makes is albumin. Now, do you remember what one of the primary jobs of albumin is? Albumin is the plasma protein that gives your blood a lot of its osmotic drawing power, right? So if you're not making albumin, your blood loses its osmotic drawing power, fluid is going to leak out of the blood vessels into the tissues, and you get edema, right? Now does it make sense why the ascites can get so bad? Because there's not albumin to hold the fluid in the blood vessels, so it all leaks out into the peritoneal space. The liver's also supposed to be making clotting factors, right? So if the liver's not making clotting factors, what problem do you have? You're going to bleed, right? Now, people with cirrhosis have a lot of reasons to bleed, right? Because not only is their liver not making clotting factors, but remember, the liver's not making bile, so you have trouble absorbing vitamin K. And even if your liver were making clotting factors, they probably wouldn't work because you don't have the vitamin K to help them be produced in a functional form. Also remember that because of the splenomegaly, the spleen is removing a lot of the platelets, and so we're missing both clotting factors and platelets now. So now does it make sense why if somebody ruptures their esophageal varices, the bleeding can be so bad that they might actually die? Because they don't have clotting factors, they don't have platelets, so they can't stop the bleeding. Okay, the other thing that we said the liver is supposed to do in terms of protein metabolism is it's supposed to take the breakdown product of protein metabolism, which is ammonia, and convert it to urea so it can be excreted by the kidneys. If the liver fails, the levels of ammonia are going to build up. And remember we said ammonia is a neurotoxin, right? And so we're going to see a lot of neuro issues. People will get hepatic encephalopathy. There might be changes in their level of consciousness. They might become agitated or confused. They might have seizures. They might have speech problems. They're probably going to have difficulty performing certain purposeful movements. Like one of the things that the doctors do to assess their neurostatus is they look at their handwriting. And over time we notice patients' handwriting degenerating because they don't have that coordination of their purposeful movements anymore. Worst case scenario, they can actually fall into what we call a hepatic coma because of the accumulation of ammonia, which you remember is a neurotoxin. One kind of interesting symptom that's a part of hepatic encephalopathy is called asterixis. And the layman's term for asterixis is liver flap, because when you ask a person to dorsiflex their hands and hold it there, their hands will kind of jerk and it'll look like they're kind of flapping. To check for asterixis, we'll ask the patient to extend their arms and dorsiflex their wrists and to hold it. And they will not be able to hold that position. Their hands will just kind of jerk and it'll look like they're spasming and, kind of like they're flapping up and down. Not quite like this picture. I actually do have a YouTube video that I can show you in class. But the asterixis is part of the neurosymptoms that you're going to see when the ammonia levels get too high. Now, we said that the liver is supposed to metabolize drugs and hormones. In other words, they're supposed to break them down so they can be excreted from the body. So if the liver fails and it can't do that, we're looking at some drug toxicities, right? Because the drugs aren't going to be able to get eliminated from the body. And we're also looking at some hormone imbalances because the hormones aren't going to be able to get excreted from the body. And so we're going to see maybe some overproduction of hormones like androgen and estrogen, aldosterone, antidiuretic hormone, cortisol. If you think of what all those hormones do, we're going to see fluid and electrolyte imbalances, with the aldosterone and the ADH. And also with the cortisol, probably some problems with glucose metabolism as well. Now, the liver is also supposed to filter and clean up the blood, right? Those little phagocytic cells that we call Kupffer cells in your sinusoids are supposed to remove bacteria and foreign stuff. The function of the Kupffer cells can be impaired in cirrhosis. Not to mention that even if the Kupffer cells were working, remember, a lot of the blood is bypassing the liver and getting shunted to some of these other vessels that don't present as much resistance to blood flow. So a lot of the blood in the body is no longer getting filtered. So what kinds of problems would you expect to see? Infections and probably even sepsis, right? Because some of those organisms that might have gotten into your blood from the GI tract are no longer going to get cleaned up. The last problem I want to mention that's associated with liver failure is that we find that a lot of patients, once they go into liver failure, will then develop renal failure on top of that. Okay, and we don't exactly know why that happens. There are a lot of theories as to why that happens. Most of them seem to think that once the liver fails, that somehow affects blood flow to the kidneys. Okay, and if the kidneys aren't getting blood to filter, they can't make urine, and so they're going to fail as well. But if you think of all the problems that we just talked about with liver failure, and then you add all the problems of renal failure on top of that, now you have somebody who's in really bad shape, right? And I just stuck this picture in there because this is another way to look at how liver failure can eventually affect blood flow to the kidney and cause renal failure as well. But, I'm not going to test you on all of these details, so don't worry about it. This is just for those of you who are really curious. As far as blood work goes, in addition to the things that we've already alluded to, like we said, there's going to be anemia and thrombocytopenia, there's going to be high blood ammonia levels, and so forth. You as nurses are also going to be monitoring what we call liver function tests. Okay, and the liver function tests can be broken down to a couple of different categories. First of all, we have the tests that kind of indicate whether there's inflammation or injury to the liver cells. So we already talked about AST and ALT. We're going to throw in an extra liver enzyme here, which is LD. These are, you remember, enzymes that are found inside the liver cells, and if you find high levels of them in the blood, what does that tell you? It tells you liver cells have been damaged and their insides are leaking out. Okay, so we would expect these liver enzymes, AST, ALT, and LD, to be increased in the blood in cirrhosis. Okay, then we also have some tests that measure the ability of the liver to make proteins. Okay, because remember we said that's one of the jobs of the liver is to make protein. So if the liver fails, it's not making protein, we would expect serum protein and serum albumin levels to drop, right? Because the liver's not making them. Okay, we also will throw in prothrombin here, right? Prothrombin is a clotting factor, and we know the liver's supposed to make clotting factors, right? But what we're measuring here is PT, which stands for prothrombin time. So notice we are not measuring the level of prothrombin. we're measuring prothrombin time. So in other words, we're measuring how long it's going to take the blood to clot. Okay, so if the liver is supposed to make prothrombin and the liver fails, we expect the level of prothrombin to drop, right? And if the level of prothrombin drops, what is that going to do to the time it takes to clot? It's going to take longer to clot, right? So prothrombin time is going to increase. Okay? Now, I just threw in that line on the bottom so that you'll know that PT and PTT are not the same thing, right? Sometimes people see PTT and think, oh, that's prothrombin time. That's not true, okay? Prothrombin time is PT. Okay, PTT is measuring a different clotting factor, a different thing totally, okay? You'll learn about that when you get into adult health too. Don't even worry about PTT right now. Just know that when we're measuring liver function, we look at PT, prothrombin time. And remember, we're not measuring the amount of prothrombin in the blood. We're measuring how long it takes to clot. So if the liver's not making prothrombin, it's going to take longer to clot. Okay, so the prothrombin time should go up. And just because students get this mixed up on the test so much, I threw in an extra picture to remind you that we're not measuring the level of prothrombin, we're measuring how long it takes the blood to clot. So again, notice that PT is going to increase, right? Because it's going to take longer to clot. Okay, serum protein and serum albumin levels drop because the liver's not making them. Okay, but prothrombin time is going to go up because it's going to take longer for the blood to clot. All right? All right, the last group of liver function tests that we look at are things that measure the liver's ability to excrete bile. Okay, so since the liver isn't making bile, right, what's going to happen to bilirubin levels? It goes up because there's no bile, so the bilirubin has no way to get into the GI tract and out of the body. Okay, ALK Phos, or ALP, is another enzyme that is also made in the liver, and it also gets excreted through the bile. Okay, so if the liver's not making bile, not only does the bilirubin not get excreted, but the ALK Phos doesn't either. So both the bilirubin and the ALK Phos levels are going to increase. All right? So notice when you're looking at liver function tests, all of these liver function tests go up except the serum protein and the serum albumin. Okay, those two are going to drop, and that actually makes sense, right? Because you know the liver makes albumin and plasma protein, and since the liver's not making it, those levels are going to drop. All the other liver function tests are going to increase, all right? As far as interventions for cirrhosis, there's not a whole lot we can do to correct the pathology of cirrhosis, right? We don't know how to change the scar tissue back into functional liver cells. So mainly we're stuck with just treating the symptoms. And by treating the symptoms, I mean, we try to correct any fluid or electrolyte imbalances that have occurred. We might give medications to try and decrease the portal hypertension. And if we decrease the portal hypertension, hopefully there will be less portosystemic shunting and there will be less formation of varices. We are going to try and minimize the hepatic encephalopathy, which you remember is what happens when the ammonia levels get too high, right? So we might do things like put people on a low protein diet, because you remember ammonia is what happens when we metabolize protein. So if we put people on a low protein diet, hopefully they don't make as much ammonia. We do have some drugs we can give people to help them excrete the ammonia from the body. One of the most common drugs that we use to do that is called lactulose, or Sefulac, and I'm not going to test you on the name of that, but just in case you do care for a cirrhosis patient in the near future, you might be giving that drug, and while it does help to lower the ammonia levels, it does it by excreting the ammonia in the stool, and I have to tell you, it gives patients really bad diarrhea. Okay, so if you give this drug, you will not forget it. But the thing is, I would rather have a patient with diarrhea who's not confused than to have a patient who doesn't have diarrhea who is confused, right? So, pros and cons. Okay. Of course, we should be avoiding anything that's hepatotoxic, right? So they should not be drinking alcohol. And we have to be careful what medications we give these people, because there are a lot of drugs that are hard on the liver. We may need to change some of the medications that they're on to drugs that are less hepatotoxic. And we might need to decrease dosages, because remember, the liver is supposed to break down drugs so that they can be excreted from the body. And if those drugs aren't being broken down, we might see some drug toxicities. By the time we get to liver failure and end-stage liver disease, the only thing that we can really offer is maybe a liver transplant. Now, I threw in this slide because I thought it's really interesting. It says that you can take one donor liver and split it into two parts. There's usually a bigger lobe and a smaller lobe of the liver. And they'll take the bigger part and give it to an adult, and the smaller part and give it to a child. And each part can actually grow to the full organ in about a month. Now, it's not going to look the same shape, but who cares what shape it is as long as it does the job, right? And so the cool thing is that liver that's the part of the liver that's given to the child can kind of grow as the child grows. So it's not like, when this child becomes an adult, now this liver is not big enough anymore, because it can enlarge and still, do everything that child needs once the child has become an adult. Pretty cool, huh? There was a lot of experimentation in the past with living donor procedures, but I think they stopped doing them for a while because I think it was the donor that started having complications. But they tried to work around a lot of those problems, and so they are trying the living donor procedures again. They are still way less common than the deceased donor procedures. But, it is a thing to keep your eye on in the future, because there is nowhere near enough deceased donor livers available. So if we could somehow do the living donor thing, there might be the possibility of being able to meet the needs of more patients. All right. That's it for today. If you have questions, make sure you forward them to me, and I will see you in class. Bye.